This presentation is going to cover the basics of the muscarinic antagonists. Anticholinergics are drugs that will block the activity of the cholinergic receptor. They're acting directly at this receptor, where their main job is to block the actions of acetylcholine. So there's three categories of anticholinergic drugs that block acetylcholine. And these categories are the muscarinic antagonists, the ganglionic blocking agents, and neuromuscular blocking agents. Again, all three are blocking the actions of acetylcholine. But of the three, muscarinic antagonists are the most commonly used in healthcare. And although the muscarinic antagonist is a more specific term, more often clinically we're going to use the terminology anticholinergic drugs. Now, the muscarinic antagonists, they represent atropine and selectively block the effects of acetylcholine at this muscarinic receptor. The ganglionic blocking agents, they're going to selectively block the ganglionic nicotinic N receptor, and the neuromuscular blocking agents, they're going to selectively block the effects of acetylcholine at the nicotinic M for muscle receptor, and this is going to be at the neuromuscular junction. The ganglionic and neuromuscular blocking agents can be used in specialty settings, but we're not going to discuss these things because if your patient is on one of those drugs, you've referred them out to a specialist. So more commonly, it's going to be the muscarinic antagonists, which are also called anticholinergics. Now, we recommend the same approach, though, to learning all the muscarinic antagonists as we would do for the muscarinic agonists. So make sure you go and listen to that presentation as well. There is a table in your textbook that will help you to understand the anticholinergic drugs a little bit more in detail, and we're going to look at that in just a second. It's going to list the three major subtypes of the cholinergic receptors. Again, it's the muscarinic versus the nicotinic N and the nicotinic M receptors. And it's going to tell you the location, the response to activation, and the drugs that prevent this activation, which we call antagonists. You can see here that examples of these anticholinergic drugs are listed here. You may have noticed we've talked about some of them, like scopolamine earlier this semester. We've talked about dicyclomine as well. And if you are forgetting any of them, just go take a break before progressing on and look these drugs up. So here is the chart that I was talking about, and you can see with the receptor subtypes under muscarinic, these are going to activate and block sweat glands, blood vessels, and any organ that's regulated by the parasympathetic nervous system. And because we're talking about the muscarinic antagonists, we are blocking these things from occurring. So if we have the receptor activation, we'll have an increase in gland secretion, a decrease in heart rate, and we're going to promote smooth muscle contraction. So an example of a receptor antagonist is atropine. And you can see with the nicotinic N, it's working on the ganglia of the autonomic nervous system. With nicotinic M, it's the neuromuscular junction. So these are some common ways that we will use muscarinic antagonists in primary care. When someone has an overactive bladder, we may use oxybutynin, as a prototype drug. And usually this is the first line treatment. If they fail oxybutynin, then you can move down into the other drugs like sulfenicin and tolterodine. Those are ones that are very common. But we're using these drugs to stop this urge incontinence or urgency incontinence, which is what is describing overactive bladder. And so the pathophysiology of this has to do with addressing the four major symptoms of overactive bladder or urgency incontinence. We're trying to limit the urinary urgency, which is that sudden desire to urinate. Also the urinary frequency, which is defined by voiding, 8 to 12 or more times per day. Nocturia, waking up at least 2 or more times at night to void, and the urge incontinence, meaning that your patient would have this involuntary urine leakage that comes with urgency. So in most cases, this is due to involuntary contractions of the detrusor muscle of the bladder. That detrusor muscle is that smooth muscle component of the bladder wall that allows it to contract and empty. And these contractions are often referred to as detrusor instability or detrusor overactivity. Okay, so that's what's defining the mechanism behind overactive bladder. We don't want to confuse stress incontinence with urge incontinence. It's defined as an involuntary leakage by activity. And sometimes stress incontinence is called giggle incontinence because it's with like that bearing down with laughter or giggling. But things like sneezing, coughing, exerting yourself through activity, those are stress incontinence related and not urge incontinence. Okay, so with overactive bladder being a common disorder, we need to be very comfortable with prescribing a muscarinic antagonist or an anticholinergic to help our patients with overactive bladder. And what we would do is try to prescribe, again, this baseline, first line oxybutynin. And if it doesn't work at the lower dose, then you can move up to the higher dose. And we're going to see on the next chart what those doses are. Now, of these drugs, they will, because they're working on that muscarinic site, we're trying to decrease or limit the fluid production. And many times, patients that are on these drugs will complain of symptoms like dry mouth and dry eyes because we're essentially drying up everything. Now, muscarinic antagonists don't come without concerns, and you can get into a point where it can become toxic to your body. And the patients will describe being very hot. They feel very dry. Again, this is like super dry because we do want them to dry out a little bit because that's what's helping again with their overactive bladder. And you can see the other states that are common as well. And so there is a mnemonic actually that helps you to remember these signs and symptoms of the anticholinergic toxicity. So we think of hot as a hair, so they get into this hyperthermic state, dry as a bone, dry eyes, dry mouth, dry skin, red as a beet. They're going to look very flushed and erythemic, blind as a bat. So they get mydriasis, which they lose some of that visual acuity, and mad as a hatter. So they will perhaps be in a state of delirium. Okay, so use that mnemonic to help you to understand anticholinergic or muscarinic antagonist type toxicities. Now, there's also anti-muscarinic poisoning that you want to think about too. And these are sources that have to do with the natural products that will cause this effect, like belladonna is one of the major ones that most providers will think about in terms of antimuscarinic poisoning. And there's some selective antimuscarinic drugs like scopolamine and atropine that can cause that too. Remember that drugs with pronounced antimuscarinic properties, similar, right? Antimuscarinic properties like antihistamines, tricyclic antidepressants, they can also cause toxicity as well. Now, just because we're talking about overactive bladder, I do want to bring up an FDA approved drug that is not considered an antagonist or muscarinic antagonist, but it's a beta 3 agonist, and it's called Mirabegron or Myrbetriq, and we use this for the management of OAB. And I like to use it compared to these anticholinergic drugs because you're not going to get some of these same side effects of toxicity. And again, remember that feeling very dry mouth, dry eyes, dry skin becomes a problem for our patients. And so I like this drug, but it is cost prohibitive for many patients. Depending on what their insurance is, the cost is still pretty high. Many times I have to prescribe at least oxybutynin and kind of go down this line of a couple before the insurance company will approve Myrbetriq, but it is something to keep in the back of your mind for overactive bladder management. Again, these are beta agonists. Myrbetriq is a beta agonist. Okay, so looking at the pharmacokinetics of different anticholinergic drugs for overactive bladder, you can see here, like I said, I would focus on oxybutynin here on this chart. So they do go by the names Ditropan. You might have seen Gelnique and Oxetrol as well. So it does have a metabolism through the hepatic system with the CYP3A4 enzyme, and the half-life of the extended release is 2 to 3 hours, 13 hours, where the intermittent release is 2 to 3 hours. I always will prescribe the oxybutynin extended release. Now, some people really like the transdermal patch, and that actually will give about 64 hours in terms of half-life. It is eliminated through the urine. And some other ones to note, just because they are the more popular ones, are sulfenicin, which is Vesicare, Toviaz is something I'll use, Vilsteridine, and Detrol, which is Tolterodine. These are other drugs that fall within the muscarinic antagonists. So of these drugs listed on this chart, those are the 4 that are most commonly used.